was not showing. So, good evening, Viras, sir. And first topic given to me is what should be the first line.
Yeah. So good evening, everyone. Welcome to the NETConnect. It's a small initiative that we have started where we are going to discuss challenging and unusual cases in the field of neuroendocrine tumors. But before we begin, just a small introduction about who we are. So, as a company, Genova, we aspire to transform the healthcare of millions of people, especially through implementation of technological solutions, and the process to be in the top 10 technologically driven companies in the world. How are we going to do it? Basically, we innovate biomanufacturing technologies and we manufacture biotherapeutics. And that's how we are going to achieve our dream of transforming healthcare. We are currently a Pune based biotech company in the business of transforming healthcare again. So, in 2006, February, Genova was established. And since then, it's been 2 decades of excellence in innovation from our end. So we've launched Wintor, Relaxim, Emgrast, Pegex, and a lot of vaccines as well, even Hamsil for oncology, Tenectase for AIS, and recently even the COVID vaccines from our end. And finally, last year we launched the Hamsil Junior again for pediatric cancers. So we are currently in the market of stroke care and management, mRNA vaccines, and cancer care and management as well. And apart from that, we are leaders in the field of renal care, ophthalmology, cardiac care, etc. With this, without further ado, it's a pleasure to introduce and welcome our moderator and speaker for today, Dr. Krishna Chaitanya. Of course, sir doesn't require any introduction. Sir is a medical oncologist from MNJ Hospital, Hyderabad. So we look forward for your insightful discussion today. Welcome. And we also have an expert panel here with us today, Dr. Viraj Lavangia, Dr. Haridas Mani, Dr. Arun Raja, Dr. Soumya Panda, Dr. Srinivas Kulkarni, Dr. Ankit Batra, Dr. Ajay Yadav, and Dr. Farad Afzal Sheikh. So with this, I hand it over to Dr. Krishna Chaitanya for an insightful discussion on the challenging and unusual cases, especially in the neuroendocrine tumors. So with this, sir, I'll stop sharing the screen from my end and over to you.
Thank you, Dr. Ronak, for that kind introduction. So let me share my screen. And I hope all panelists are there except for Dr. Soumya, Dr. Srinivas, and Dr. Fahad.
Yeah, I think they must be
Great
facing
job,
some
man.
technical
Yeah.
challenges.
Fine. That's fine. Yeah.
Yes, sir, we can see your screen.
That's good. So good evening, all panelists. Let me welcome Dr. Viraj. He's my friend. Dr. Viraj, you are there? Dr. Viraj?
We can see he has joined.
Yeah, that's fine. Okay. Dr. Haridas?
I am here. Yes, sir. Krishna, sir, I'm here.
Sure, sir. Okay. Dr. Arun?
Yes, sir, I'm available, sir.
Yeah, Dr. Ankit and Dr. Ajay.
Hi, good evening.
Yeah. So good evening, all. Actually, morning I shared some my cases, but slide deck preparation got delayed, so I just made into concised preparation, and it's like very useful what we do in the general clinical practice. So let me start with the first case. She is a 65-year-old female. Presented with recurrent abdominal pain, right iliac pain, and on evaluation, she was found to have multiple liver lesions and a ileal mass. And the biopsy was done from the liver, which was showing a well-differentiated high-grade neuroendocrine tumor with a Ki67 of 30%. So with the evaluation, with the diagnosis and the staging workup, we found to have it's a metastatic neuroendocrine tumor, high-grade, with originating from the ileum, multiple liver metastasis, and the mesenteric lymphadenopathy. So this is the commonest presentation what we see in the neuroendocrine tumors. So with this, I would like to ask Dr. Arun So how do you grade them? Like, we know there are three grades of NETs. How do you differentiate them from the neuroendocrine carcinomas?
So as so it is grade 1, grade 2, or grade 3. So what we see is based on the K67 index, if less than 2, more than 3, and more than 20. So for our cutoff will be what to say, if more than 20 and 20 to 50 or 70, I consider them to be carcinoma, provided the ISC is there and that is what to say, high risk features are present, then I consider it's a carcinoma upfront. Otherwise, well differentiated high grade, grade 3, more or less the carcinoma versus the high grade tumor, we treat more or less same.
All right. So you are saying a well-differentiated tumors may be a high grade, but a poorly differentiated cancer tumors can be labeled as carcinomas, even though they also have a key 67 of more than 20% and mitotic index. If they are poorly differentiated morphologically, we can call them as a carcinomas rather than grade 3 neuroendocrine tumors.
Moreover, the ISC defines everything, sir. So ISC will help out. So whether it's going to be what to say, in ISC we see that NSC and chromogranin A. So
Right.
we'll take a
Okay.
call on based
Those
on
will be
that.
positive here, but
Possibly
not
in
yeah.
but only the Ki-67 index matters a lot for us.
Right, right. I understood. I got your point. Dr. Haridas, any point to make here? Like, differentiating the carcinomas from tumors,
Yes, sir.
high grade NETs
Yeah.
versus NEC.
So for that is neuroendocrine tumors, sir, we have it's grade 1, basically K67, less than 3, then it's 2 to 3 to 20%, and more than 20%. But for neuroendocrine carcinomas, usually the K67 is more than 50%.
Right. Totally agree.
Then they are highly aggressive tumors.
Right. And differentiation also matters. Like, these
Exactly,
are all
sir.
well-differentiated tumors.
Yes.
So carcinomas are poorly differentiated.
IHC wise, we look at NSC, chromogranin, P53,
Right.
and basically these are all positive for NETs and NECs, but patchy
Right.
positivity is usually seen in chromogranin, sir.
Right.
Then
And Dr.
morphological
Viraj,
appearance also, sir.
Viraj, if you are there, can you just pitch in?
Yeah, hi.
Hi.
You, it's
So
the same question to
grade
me.
3 NET versus NEC.
Yeah. So it's very interesting that neuroendocrine we have, uh, completely different division between G3, well differentiated G3 nets and NEC. Although, we've seen NECs with KI of 4050 and well differentiated nets G3 with KI 4050, I think it's more of morphology where you see carcinoma versus the tumor, point number one. And point number two, typically these are the ones which still retain some DOTA expression and have a better prognosis than the out and out, the NECs or the small cell that we see. So
Right.
yeah, it's very
Totally agree.
important. The pathology is very important in this disease.
Right. Totally agree. So SSTR expression is also important. Right. So for this case, it's a well differentiated metastatic small intestinal neuroendocrine tumor. So what would be your management, next step in the management? Dr. Ankit Batra? It's a metastatic disease, well differentiated, high grade.
So coming on to the first, starting with the previous point, I would like to say that every patient is different. Just strictly on the basis of Ka67 cutoff, we cannot treat them. So
Correct.
it's very important to see the clinical behavior of the disease, how
Right.
fast the tumor is growing, and then the morphology also matters. Apart from the differentiation, what type of cell, whether small cell or large cell are there. So that makes a huge difference in treatment selection, because even with the Ki67, unless and until it is very, very high in the like more than 55 or 50, but if it is in the tune of 30 to 50, then these cases are very tricky. And for them, we have to individualize the treatment and take multiple parameters into account before we finalize the treatment for them, because some of them will be better for the chemotherapy, and some of them can be better for just the octreotide therapy.
Right. Totally agreed. So this case, next, what step you want to take it?
So this is, I think, a slow growing tumor with a borderline K67 of 30%. So I would like to see the SSTR expression as well in this case. And if it is high, definitely would like to plan octreotide because that is much simpler and less toxic treatment for the patient.
Okay, where do you consider surgery in this metastatic presentation?
So surgery only and only if R1 resection is feasible. If R2 is there, then I would like to avoid it.
Okay, so whenever there is a complication like obstructive symptoms or the intractable pain or any kind of bleeding,
Yeah,
so
so
any
that's
tumor related complications, we are
yeah,
going to
that's
prefer the
altogether
surgery.
a different scenario,
Right,
and I
right.
think that will be a more of a palliative surgery to palliate the symptoms of that disease rather than a
Right.
definitive treatment.
Right. But in NETs metastatic, it's a well differentiated tumors. Even the surgery also will improve even if it's not a way the primary surgery itself will prolong the survival and as well as it will control the symptoms also.
Yeah.
So this case
But
underwent a
but for
palliative. Yeah.
just majority of the cases, we see that the primary is very small and the metastases are very large. So
Right.
these kind of patients where the surgery of the primary will help in palliating and symptoms and increasing the PFS, they are very less.
Right, agreed. So this case, because it's a ileal mass and he was having intractable pain and multiple times he had a abdominal pain and admission. So he was underwent a palliative ileal resection and he was started on octreotide LAR 30 mg once in a month from June 2021. And he continued the medication for 2.5 years every month and he was on surveillance with Dotanac scan. I mean the follow-up with the Dotanac scan every 6 months. And after 2.5 years, what is the general course of the disease of NET? There was a new lesion, which was Dotanac uptake was there, Dotatate uptake was there, and there are new lesions, and as well as the previous lesions, there was increased uptake and size. So at this point of time, I want to ask whether what is your practice? Like you want to, because now we have an approval for combination of lutetium and octreotide, but earlier, like in 2021 and all, we used to use just a somatostatin analog. So in your practice, anyone uses lanreotide or everyone is comfortable with octreotide LAR? Dr. Ajay?
So octreotide LAR is the first choice.
Okay, any panelists are using lanreotide?
We usually don't use
Right.
lanreotide.
So these are the two studies. One is for octreotide, that is PROMIT study, and the clarinet study. Definitely, compared to the placebo, there is a significant improvement in the progression-free survival, 6 versus 14 months, whereas in lanreotide is much better. That is like, which is not reached versus 18 months. So this case received octreotide LAR. After 2.5 years, there was a progression and there is an uptake, SSTR uptake. So now what would be your treatment of choice? Dr. Haridas?
Yeah. So in this patient, I would go for PRRT, sir, if possible.
Right.
But again, patient's performance status, that's most important for me, sir.
Okay. So what are other factors you would consider when you are thinking about lutetium?
Sir, again, the amount of or the volume of metastasis that we have,
Right.
performance status, then I would look whether there is any renal function, so the performance.
Right.
Status,
Okay.
sir.
Organ reserves, bone marrow function, performance status. And one more important thing is there is a contraindication for this PRRT therapy when there is an extensive peritoneal disease.
Yes.
Because once we start the medication, this therapy, they'll go into acute intestinal obstruction. So that is a absolute contraindication for doing this PRRT therapy.
Yeah.
So, and extensive liver mets and all are fine. We can go ahead with this therapy. And this patient received lutetium therapy for 4 doses, once in 8 weeks, and continued on octreotide LAR along with the PRRT. And he was not symptomatic for there was no functional, it was not a functional tumor, it is a non-functional tumor, but he was symptomatic for the disease burden itself, the liver lesions itself. So after the lutetium therapy, there was a partial response, and he was just continuing she was just continuing the octreotide LAR. So in your practice, every panelist will agree that lutetium, once they progress on SSA, so lutetium is the second line therapy, or anyone wants to opt any other options like any other oral molecules. Dr. Arun?
This lithium is not available everywhere. So to be practical, I start with everolimus.
Okay.
So if there is a progression, then I can consider recent data cabozantinib, or if
Okay.
the tumor burden is high, then I choose for the traditional cytotoxic agents.
Okay.
This is
So
my way
because
of
of
usage.
unavailability of the lutetium therapy, you are choosing those molecules.
Yes, sir,
Otherwise, you
because
would prefer the
otherwise
lutetium.
this is the go for therapy.
Right. Okay. Dr. Viraj?
Yeah, I agree. So typically, PRRT follows octreotide failure. However, we have used CAPTEM before if it's a pancreatic primary, and especially when we don't have, let's say the clinic score is not 4, if it's 2 or 3, we have been tempted to use everolimus or CAPTEM before PRRT. But by a majority of cases, the PRRT is our reflex second line.
Right. Yeah. I hope everyone agrees with that. So this is the study, NETTER-1 study in the second line who progressed on upfront SSA compared to the high dose of octreotide LAR. You can see the survival curves, how far they are separate, and it is the progression-free survival. It is not reached over a follow-up of around 3 years, whereas it is median is only 8.4 months with the high dose of octreotide, and hence PRRT is the standard of care once they progress on the SSA. And there's a 80% reduction in the risk of progression or the death when you use PRRT. So these are the contraindications which we are discussing: a poor performance status, diffuse peritoneal metastasis, or inadequate renal function or bone marrow reserve, and especially important thing is the presence of the SSRT expression. If it is there, only the PRRT is going to work. That we are all aware of. So if lutetium is not available, as we were discussing with, as the other panelists were also saying, we have the other options like the everolimus or CAPTEM. We are like, a lot of people are very much fond of using the CAPTEM irrespective of the grade of the disease, but definitely they are going to work in a high grade, well differentiated tumors. And of course, cytotoxic chemotherapy may be in very later lines where we don't have any of these options. So we have the evidence, the scientific evidence of using these molecules, everolimus. When you take the 3 studies, the RADIANT-2 study, which was done in the metastatic NET with carcinoid syndrome, the GE, gastroentero NET with carcinoid syndrome, when you compare with the placebo, there is no benefit of using everolimus. Only octreotide alone was sufficient when there was a carcinoid syndrome. But in the same group, when you take the non-functional tumors, when they don't have the carcinoid syndrome, and once they progress on the SSA, that is based on the RADIANT-4 study, you can see the placebo versus everolimus. It was 4 months versus 11 months. There is a significant progression-free survival benefit when you use everolimus. So everolimus can be used either in the non-functional NET metastatic or in the pancreatic NET, which Dr. Viraj was saying. So in a pancreatic NET, definitely the everolimus is going to work compared to the placebo. So this is the studies regarding the everolimus use in NET. So when you compare the second line therapies in GEP NETs, the Netter is the preferred choice because there is a statistically significant improvement which we have seen in the Netter-1 study, whereas the RADIANT-2 study did not show any benefit with the addition of everolimus to octreotide versus octreotide, especially in carcinoid syndrome patients. So this is how we sequence the treatment in small bowel NET. Somatostatin analog initially, and check for the on progression, check for the strong somatostatin receptor expression. If it is there, the preferred choice should be lutetium dotatate, or if it is a weak expression or extrahepatic mets are there, the choice would be everolimus. And Dr. Ankit, what about the liver dominant disease? What about the hepatic directed therapies?
So basically, in terms of this hepatic arterial embolization, seems to be a theoretically good option, but again, accessibility and expertise of the IR is not available everywhere. So it is like not used in every other patient, but yes, if the accessibility and the expertise is there, then definitely sounds to be a very good option. But practically, we have not been able to take advantage of this liver directed therapy, especially in terms of arterial embolization, much as we should have used that.
Yeah, I totally agree. So we can use it, but expertise is the issue. And Dr. Ajay, your take on that?
Yeah, suppose there is single lesion in the gut and we have taken it out with surgery and there are 2-3 lesions in the liver, then definitely it will work.
Right. Okay. Even the data also says that, even if it's all a retrospective series and a small prospective studies, there is a very high response rates when you use the arterial or the hepatic directed therapies, and there is a high rate of symptomatic response. If the patient is symptomatic because of the huge liver mets, maybe we should utilize this hepatic directed therapy. And of course, a lot of other factors also will influence whether the patient is going to go for it or not. And the toxicities are the major issues when you are giving, if it's an extensive disease and you are using the hepatic directed therapies, maybe the toxicities will be the issue. And the bilobar radioembolization can lead to long-term hepatic dysfunction, and it can be considered primarily for a segmental or a lobar treatment and for the aggressive disease. So this is the hepatic arterial therapies. And if at all this patient comes today, initially we have started only an SSA. So would you be interested in starting the lutetium therapy upfront along with SSA, Dr. Viraj?
We also have Dr. Soumya Panda here.
Soumya sir, you can take up this case. Dr. Soumya, please take up this case. So the initial case which I presented, in 2021, it's a metastatic, well-differentiated, high-grade neuroendocrine tumor, not carcinoma, and initially started with somatostatin analog used for 2.5 years, then progressed, planned for lutetium therapy. If at all now the same case comes now, is it like we are still using only somatostatin analog, or are we pushing the patient for a combination of lutetium and octreotide LAR?
Yeah, thank you, Dr. Krishna. But still, means in our clinics, data is there from Netter too, that we can combine that. But still, we are using the same octreotide, and then we are trying to sequence it because of the lack of OS data from that. So that's why until and unless you want a very fast symptom, we usually try to avoid. And most of the patients, they are not very symptomatic initially, so they respond well to octreotide. And so in the clinic, still it is octreotide LAR. Data is there from Netter too.
I totally agree. And Dr. Haridas, you want to add anything to that?
Yeah, sir. Yes, sir. So again, lutetium therapy is not frequently obtained in all those metropolitan cities or any cities, right, per se. So I would suggest even chemotherapy per se in this setting. I would go for etoposide-based chemotherapy as a bridge before I can push forward for any further treatment, sir. So in
So we're
my
talking
setting,
about NET, not NEC.
oh,
We're
sorry.
talking about
Yes, sir.
NET.
NET. I'm sorry, sir.
Yeah,
So
well
NETs,
differentiated.
yeah. So in NETs per se, I would go for octreotide-based therapy as of now, sir. Yeah.
Right. Okay. So as Dr. Soumya was mentioning, you can see the survival rates. It's almost like, even if you sequence the therapies, we are going to achieve the same kind of, the progression-free survivals if you sequence the SSA followed by the lutetium. But if it's available, maybe, that is the preferred choice right now, so that we can get a better responses, faster responses, and we can just continue the octreotide as a maintenance after the initial period of treatment. 4 cycles of combination treatment. So this is how we get the responses when you combine the lutetium and octreotide or lutetium per se. We can see the objective response rates crossing almost 40%, but it's only less than 10% when you use octreotide arm. So these responses will help in getting the faster responses and symptomatic benefit, but the survival is still, doubtful. So this is the pediatric study. More than 12 years old. It's been approved based on the NETTER-P study. And this is regarding the hepatic artery embolizations. Wherever it is useful, for symptomatic benefit and the disease control, we have to utilize it. So that is the first case. Then second case, it's a 52-year female found to have a head of the pancreatic lesion with liver metastasis and peripancreatic lymphadenopathy. Again, the biopsy was done from the liver, which is a well-differentiated pancreatic neuroendocrine tumor, which is, Ki67 1%. So this case, how do you want to take up further? Dr. Ajay?
So octreotide LAR will be the first choice.
Yeah.
Because this patient is having low-grade tumor and there is possibility that this patient may have control of disease for many years. So I will start with octreotide LAR alone. single
Yeah.
agent.
Responses will be long lasting and toxicities will be much less and easily manageable, right? And it's not a functional tumor, it's a non-functional pancreatic NET and very small, probably I think surgery, if you are doing it, it has to be a Whipple's, it's a morbid surgery. So maybe we can just start with SSA and watch for the progression. And Dr. Ankit, your take on this?
Yeah, I concur with my previous panelist. And obviously, the first choice in this case of scenario is octreotide LAR. If the patient is not responding, and there is a progression, and as you say that there is no uptake, in that case, it's become a bit tricky. And is in second line, definitely with such a low K67 and non-expressing, everolimus is still a very good option in current scenario as well.
Right. So the case was on almost like 4.5 years on the SSA. Then there was a progression, and surprisingly, there was no TOTA uptake at all. So this case is how we sequence, like based on the SSTR. If it's positive, we are going to give the lutetium therapy. If it is SSTR negative, we have to think about the other options of either everolimus, sunitinib, or captem. So out of these, what would be your preferred choice or generally your practice, Dr. Haridas?
Sir, I would start with everolimus, sir, because
Right. Okay.
yeah,
And toxicities and all, you're comfortable?
I'm comfortable that, sir, I would start at the lower dose and escalate based on toxicity. But
Mm.
from my viewpoints, Captem has got major toxicity, profile than everolimus when I chose Captem over everolimus, sir. So
Okay.
that's why I would prefer everolimus in this setting.
Okay. Dr. Arun, your take?
I stick on with the everolimus. So
Okay.
I start with the 5 milligram OD, then I escalate to 10 milligram. So
Okay.
depends on the tolerance. Usually I rarely cross 5 to 10 is a sweet spot, but 5 is the go for treatment because
Right.
the most patient won't tolerate.
Okay. Any of the panelists want to choose any other drug? Because my practice is Captem most of the time. So any panelist for either sunitinib or Captem?
Yes, we also in third line, Captem is the first choice.
Preferred choice. Okay, right, sir. Okay. So we have evidence for this. With this, we have seen the radiant studies in the pancreatic NET. You can see radiant 3 study compared to placebo. There is 4 versus 11 months with a hazard ratio of 0.35, which is statistically significant. And about the other drugs, also sunitinib also had a significant, a similar benefit, like 5 versus 11 months with a hazard ratio of 0.4, which is almost similar to everolimus. Maybe I would prefer sunitinib rather than everolimus based on the our vast experience in the RCCs and the other tumors. Whereas coming to the Captem, which I commonly use it, compared to in pancreatic NETs, compared to single agent of temozolomide, if you combine Captem, the survivals you can see the PFS, almost reaching 2 years versus 1 year with temozolomide. And the p-value of 0.02 and hazard ratio of 0.6. It is not compared to the placebo, it is compared to the temozolomide single drug, whereas in everolimus and sunitinib, it was compared to the placebo. And these are the various trials which are running, done in the pancreatic NETs. We have Radiant 3, everolimus versus placebo, and sunitinib trial, Captem trial, and lutetium versus sunitinib. Again, it's almost the same benefit what we get with the Captem versus sunitinib. What we have seen with sunitinib versus placebo is 11 versus 5, and with the lutetium, it will be PFS of around 2 years. So, and what is the role of cabozantinib? One of the panelists were talking about cabozantinib. Dr. Ankit, I think you were talking about cabozantinib.
No, I was not talking about that. But
Okay.
anyway, cabozantinib has a good place now. The only issue is the dose which was taken in this trial. None of my patient has tolerated. It's very difficult to give at that dose.
Okay. So this Alliance trial was in well-differentiated low intermediate NET and who has progressed on the previous lines of therapies. So anyone is in favor of using this in second line or third line after your SSA and lutetium compared to your everolimus, Captem and sunitinib. Anyone would prefer using cabozantinib or based on any other molecular markers? Anyone's preference is this? Dr.
Dr.
Viraj?
Sheikh has also joined.
So you said something?
Dr. Fahad is also here with us
Fahad,
today.
Dr. Fahad, can you take up this? What is the role of cabozantinib in well-differentiated neuroendocrine tumors? So we spoke about SSAs, we spoke about lutetium, we spoke about captam, everolimus, and sunitinib. So what about cabozantinib? Or else anyone else can also take up. But Dr. Viraj, if you are there, please.
So second line or third line. We would prefer to use after CAPTEM in fourth line.
Okay, so this study has shown that both in pancreatic and extrapancreatic, compared to the placebo, definitely there will be a better PFS, 4 versus 8 months with a significant hazard ratio, and overall survival is not met because of multiple lines of therapies available, both in the extrapancreatic and the pancreatic. Looks like pancreatic tumors work, respond very well, as similar to the other drugs like everolimus, sutent, and captem. It's also similar to that. And to summarize, maybe Dr. Viraj, you can just summarize maybe how to deal with the gut NETs versus pancreatic NETs in the metastatic setting. If Viraj is not there, Dr. Arun, you can take up.
So we know that this neuroendocrine is a heterogeneous one. So you divide the gut versus pancreas. So usually the gut tumors, the mid-gut tumors will be symptomatic. So they'll be what to say. The extent of the disease determines they are slow growing. So moreover, most of them will be low intermediate grade, well differentiated. More or less, they have a functional expression of SSTR. So this is regarding the gut tumor. Once you go for a pancreatic tumor, so once you the symptomatic, whether it is going to be a what to say, functional or non-functional, more or less there will be a poorly differentiated. Sometimes we have a high tumor burden and widely metastatic also. So if you see that colorectal and the rectal, rarely they are very symptomatic.
Right. So basically, we need to understand a lot about NETs. First of all, the grading of the tumor, how to differentiate it from the carcinomas, and the various grades in the neuroendocrine tumor itself, whether it's a localized or metastatic. If it is metastatic, what are the sites of metastasis? What is the tumor burden? And most importantly, the SSTR expression, whether expressing so that we can use a target therapy or not, and the functional, non-functional. The functional tumors are very, difficult to manage most of the times. It's because it depends on the which type of, pancreatic functional or the GI functional tumors. Sometimes it can be very difficult to manage them rather than the non-functional tumors. And of course, the differentiation is very important in differentiating the tumors versus carcinomas. We know that carcinomas, the survival is in just months or maybe 1.5 year maximum. But whereas well-differentiated tumors, they live for decades. And the primary site also matters, whether it's a pancreatic or a gut or lung. It also matters, and of course the biology of the disease, whether it's like indolent disease or a very aggressive disease, that also matters. So we need to understand NETs more in depth, and the sequencing therapies, as we are getting newer approvals, newer combinations of therapies, and newer drugs are available. We should sequence them well to get the good survival in this population. And Dr. Soumya, sir, can your last words on this? And of course, we have to use SSAs irrespective of these, the site of the disease, and especially in the well-differentiated tumors. Whether lutetium is available or not is a secondary issue, but SSAs are rampantly available, and that should be the first treatment of choice because of the long-term the response. Even if it's a stable disease, that's fine, but less toxic compared to any other therapies in NADs. Dr. Soumya, sir, you are there?
Yeah. So this NET is very very heterogeneous. So we also decide on the patient sitting in front of us. So much of permutation and combination is there. So suppose the NET is there and we are planning for a Whipple's operation just to remove the NET, and he lives for 20 years with lot of morbidity and is having a difficult life. Then it does means it is really a tough decision. Whereas the you can prolong something with the octreotide, and but then in that case it is not a curative. So it all sometimes requires a multidisciplinary tumor board decisions, and it's not as simple and as straight as it looks always.
Yeah, totally agree with you, sir. Yeah, totally agree. Yeah, and Dr. Ajay, your final points. Dr. Ankit?
Sorry to intervene. I have a
Yeah.
couple of things to ask you.
Sure, sir.
So,
Mm.
if you don't mind, shall I ask you?
Yeah, please.
So the thing is, you told about the differentiating between the neuroendocrine tumor and the carcinoma. In
Right.
what way in clinical practice you differentiate? That's the first question. The second question will be, what is your ideal dose of LIR octreotide, whether it's a 20 or 30? And the third question is, so for example, so you are telling that SSTR expression, you are going for a
PRRT. Right.
PRT. So if it is not available, what is the ideal sequence? So can you elaborate in a
Sure,
brief
sir.
way
The
so
first
I could.
point, the pathology matters. The good pathologist should be able to differentiate the high grade, well differentiated NET versus NEC. The treatment totally changes the prognosis, the presentation, everything will be like totally, different in both the settings. And second thing, the octreotide LAR, what I generally use is 30 mg. And maybe if the patient is a functional NET, and maybe once in a month, I'll reduce it to once in 21 days also. If it is a functional NET, if they need more, I'll do that. And generally, I don't start with 20 mg at all. For all the patients, it's 30 mg LAR. And third thing, if the lutetium is not available, generally I tend to refer to the other centers where it's available. So even if I don't have in my center, I don't have it, but in Hyderabad there are other centers where they're doing, like Nizam's Institute. Definitely, I'll push them to go for PRRT. We know that the PRRT works very well compared to any other molecule. And maybe the third line we can keep the other molecules when the PRRT fails, because the PRRT responses are long lasting, and and of course it also needs a lot of evaluation whether the patient is fit for the therapy or not. And we have to utilize whatever is available the best, for the whichever gives the good objective responses.
So another question is, so for example, you use everolimus with LIR in all cases?
No, sir, I never use everolimus at all. My practice is CAPTEM. Mine is SSA followed by PRRT followed by CAPTEM. That's my practice.
Okay. Okay. So we also spoke about the cabozantinib, for example, as per the recent guidelines. So once there is a everolimus failure, once there is a PRRT failure, so the cabozantinib has a role to play. So what, for example, we don't have access to lutetium therapy, so he failed on everolimus. So it's wise to start with cabozantinib or to go with the CAPTAM, because we know we don't have ideal sequence here.
Right,
So what's
correct.
your
So we don't
thoughts?
have data on that, but definitely we can, use, because they are like different kind of mechanism of action. Definitely we can use CAPTEM. If that also fails, maybe again we can go back to either sunitinib or cabozantinib.
Okay. Another thing you mentioned about the biomarker in your presentation. So what kind of biomarker will you assess? So
No,
you
so there is no
can you.
biomarker except for SSTR. And there are
Mhm.
some trials where they're saying, MD, um, this, for the temozolomide, whether the temozolomide is, predictive. The
So the
MDM2.
MGMT,
Yeah,
MGMT,
correct, sir. Yeah, MGMT or MDM2, that marker is there. And even SSTR also, apart from the scanning, they can do on IHC, it seems. SSTR, if that is there, again, can choose about PRRT. And of course, the key 67. These are the biomarkers, but of course, they are not going to help apart from SSTR. I think nothing is going to help us with the treatment choices.
Okay, all right, sir. Thank you, sir. Thank you so much.
Yeah, thank you, sir. So, anyone else want to make a point, or else we can close the session? And I would like to, again re-emphasize that there is no compromise on the somatostatin analog, and all the panelists agreed with that, and that is the first line of treatment. Once they progress, again, it totally depends on the resources available and the biology of the disease, how it is presenting. And with that, I would like to end. And I thank once again the Genova for giving us the opportunity, and the panelists for for the active inputs. And we can close it. And Dr. Ronak, please
Yes, sir.
take over. Yeah.
So thank you so much, Dr. Krishna Chaitanya, for this wonderful delegation. And I think it was a very insightful session for all of us, and learnings for the audience as well, from all the expert panelists, insights from the clinical discussion that we've had. So thank you so much, everyone, for joining in today evening for this wonderful session on NETConnect, which is again on the challenging and unusual cases of neuroendocrine tumors. So thank you so much, everyone. Have a good evening.
Thank you. Bye.
Thank you.
Thank you all.